We cleaned up here a little bit. We had a small spill. We're gonna go to Chris Allen, who is our Director of Suicide Prevention in the state. And he's with us on Zoom.
Good morning, everybody. Can everybody hear me okay?
We can.
Awesome. Thank you. And Stephanie, do you mind just sharing the slides when you get a second? If she's in the room.
We have a Department of Health is doing dual presentation for this time.
Oh, okay. Oh, I'm sorry. I wasn't even, yeah, I see that Nick Nichols is on with us. So if Nick.
No, presenting.
Hi, and Stephanie Bush. So you're in person with us. Okay. Great. Yeah, if you want to sit up here, that would be fine.
All the chairs to myself. I finally made it, Stephanie. I know, right? I'm also sharing the slides, which is why Chris needs me right this second.
All right, great. Do we want to wait to, okay. You get the slides up. And Chris, if you want to go ahead, and I'm assuming you and Nick have worked out between the two of you.
Absolutely.
Great.
Yeah, so good morning, everybody. Thank you, Madam Chair and committee members for asking us to present on suicide prevention in Vermont. I'm coming to you remotely as I love to share things, but I don't think anyone would appreciate the cold that I have right now. So I'll keep that to myself.
Thank you so much for that.
Good morning, everybody. Chris Allen. I'm the Director of Suicide Prevention for the state of Vermont. I work for the Department of Mental Health. I'm also a licensed independent clinical social worker, and I'm joined here by a few colleagues. So Stephanie, would you like to introduce yourself?
Yeah, thanks, Chris. So my name is Stephanie Bush. I use she, her pronouns. I work at the Department of Health, so I'll be in the second half of the presentation, and I'm the Injury Prevention Program Director.
Awesome. Very well. Well, thank you, everybody. So during this presentation, we will provide a brief overview of available resources, kind of give an overview of suicide prevention, including some various approaches, some key highlights of suicide prevention in Vermont, take a brief look at the strategic plan that was submitted in July of this past year. We'll also give some information about the Department of Health grants and look at some data, some successes, and ways to stay involved following today's presentation. Stephanie, do you mind just going to the next slide? Thank you. Yeah, so here I just wanted to kind of set the ground and share a few available resources and really just deliver a message that you are not alone. So this presentation contains references to themes of death or dying, mental health, suicide, firearms, and the prevention work we are doing here in Vermont. We encourage people to take steps needed for your emotional safety and health. This may include stepping away from this presentation. And please do know that supports and resources are available 24/7. There's a few of those supports listed here, such as 988, the Suicide and Crisis Lifeline, and you'll hear more about 988 when DMH gives testimony this afternoon. The Trevor Project, which is for LGBTQ youth and adults, and then the Pathways Support Line, which is a peer support model that's available 24/7 as well via calling or texting. Next slide, thank you. So really just trying to, part of suicide prevention is making sure that we're using common language that everybody is familiar with. And this language has changed over the past few decades here. Many people aren't aware of these changes and how we talk about suicide and also report on suicide, but know that words have the power to heal, and they also have the power to do harm. And that can be unintentional or not, and can bring out stigma and our attitudes on how we feel about suicide. So on the left side here, you'll see some suggested language of what to say instead of what is on the right-hand side. So just so folks are aware, a good litmus test for this is the words commit or committed may imply that an act is criminal or may be looked at as a mortal sin in many religions. So if you replace suicide with cancer, you would not say committed cancer or died by cancer or attempted cancer. So if you substitute suicide or cancer for suicide in those instances, it's a good way to remind ourselves of what would be appropriate language in these situations. We also would want to just focus on providing factual and direct language that is judgment-free of the person or the situation.
Can I interject here real quick, just so I can keep up on appropriate language? Do we no longer use suicidal ideation?
That is a term that we do still use, although it's primarily used in academia and not really within like the lay person's language.
Okay, thank you.
Yeah, you're welcome. And there's a source linked here on the slides that you all have that goes into far more detail about language, and there's a lot more additional information there if you're curious about finding out more. Next slide, please. So when we think about suicide prevention, there's a few different approaches, and it is both a mental health and public health issue. And so that's why we have both folks from the Department of Mental Health and the Department of Health, as we wanted to share about programming that both of us are taking on and supporting. So what is public health? It is the science of protecting and improving the health of entire populations and their communities. And why this matters for suicide prevention is that it takes a population approach, and primary prevention are critical to suicide prevention. And we also know that people that are at risk often do not seek help, didn't ask for help, or didn't get the help that they needed. So we know here in Vermont that only 32% of Vermonters who died by suicide were engaged in mental health treatment at the time of their death, which is why we want to combine a mental health approach with a public health approach so that we can expand suicide prevention initiatives beyond mental health treatment into communities, healthcare, and the general public. And I just wanted to point out this quote at the bottom of the slide that refers to the public health campaign that the Department of Health and the Department of Mental Health have been working on over the past few years, called Facing Suicide VT. And it is a website that you can also access that has ways to get involved and other available resources, and also has videos about real Vermonters sharing their stories of recovery and their experiences with suicide loss. And so it's important to keep in mind that all Vermonters have a role in facing suicide. Next slide, Stephanie. I should also add before going too far in that I can't see if people have hands up or have questions. So feel free to interject while I'm going through the slides and I can pause or move back a slide or two.
I'll let you know if someone has a question. Thanks, Chris, for flagging that for me.
Yeah, perfect. Thank you. So in addition to a public health approach, we want to also think about suicide prevention comprehensively. So this is also including across the lifespan, so that we're not just focusing on certain populations, but also focusing on all ages as well. So effective suicide prevention is comprehensive, and it requires a combination of efforts that work together to address different aspects of the problem. Hence the various puzzle pieces here. Each of them interact with each other and play off of each other in order to build an effective approach to suicide prevention. So there's a complex set of strategies as part of each of these puzzle pieces, which requires lots of partners. And it's also a way that there's numerous ways to have an impact on suicide prevention and make sure that people have the support when they need it and where they need it. There are many evidence-based practices as well that are part of each of these puzzle pieces as well. And so I just wanted to highlight a few of those buckets. As we build out a statewide program, we want to make sure that we're addressing all of these areas and that none of them are left behind or forgotten about. So in a mental health treatment bucket would be effective care and treatment, responding to crises and care transitions. And more broadly, we would want to also identify and assist people that are experiencing suicidal ideation, and also increase help seeking for those that are struggling in crisis. There's also specific strategies for lethal means and reducing access to lethal means. As we know, when people have access to lethal means, they are at increased risk for dying by suicide in a time of crisis. We also want to focus on building protective factors such as life skills and connectedness, because we know when people feel more connected to those around them and people in the community, they feel like they matter, and they're less likely to attempt or die by suicide. And then we also know that people who have been impacted by suicide loss are at increased risk of suicide, which requires us to maintain a focus on postvention. And before I move into the other slides that I have, I wanted to make sure that there's, if there's any lingering questions about kind of suicide prevention 101 or an overview of it.
Any questions? Oh, Mari.
Yes, I'm looking at the Facing Suicide program on your website, and I noticed that it was funded with a CDC grant. Is that in jeopardy? Or do you already have the money?
I'm going to cover that on the second half around the grants that the health department has that is part of that funding with this, for Facing Suicide. Sorry to cut you off, Chris.
It's a great question. And one I think that we're all holding on to the edge of our seats for. So thank you. Next slide. So here on this slide, I just wanted to provide a timeline of suicide prevention efforts in Vermont. This is by no means a comprehensive timeline, just wanting to list a few major highlights here. So back in 2008, the statewide coalition was founded and began meeting throughout the year and continues to meet 3 times a year to this day. In 2016, Vermont adopted the Zero Suicide Framework, and that started with 3 DAs, designated agencies or community mental health agencies, adopting that framework and beginning that implementation of the Zero Suicide Framework. We have, in 2022, we expanded collaboration, and Stephanie will provide more details about what that looked like. But in brief, that's when we received the CDC Comprehensive Suicide Prevention Grant and SAMHSA's GLS Garrett Lee Smith Youth Suicide Prevention Grant. At that time too, in spring of 2022, we also signed on to the Governor's Challenge, which I'll share more details about as well. In June 2022, the Director of Suicide Prevention position was created, which is the role that I'm currently in. In July 2022, 988 was implemented, and that was the nationwide 3-digit code to call for suicide in crisis. In June 2023, Act 56 was passed, which required the development of the state strategic plan and model protocols. In January 2024, the model school protocol was submitted. In July 2024, the state strategic plan, the first ever state strategic plan, was submitted along with model healthcare facilities protocols. And ongoing work is the implementation of that strategic plan and the model protocols that have been submitted over the past year. Any questions about the timeline here? Okay.
I don't think so.
Moving right along to our partners, and I'll just share really quickly that we work with many partners that support this work, including the state legislature, and that and also federal partners such as SAMHSA, the Substance Abuse and Mental Health Services Administration, and the Centers for Disease Control and Prevention. And then we also work with community and local partners as well, such as the Center for Health and Learning, Vermont Care Partners, and Vermont Program for Quality in Healthcare. And each of these partners play a part in having a successful statewide program and contribute to the comprehensive approach that I mentioned earlier. Move on.
I think Leslie has a question.
Yeah, thanks so much, Chris. It's been really interesting to follow this along over these years. And you said that the model school protocol was submitted. Could you tell me who it was submitted to and then what happens?
Yeah, absolutely. So that model school protocol was submitted to the House Healthcare Committee. So the committee, that committee and the Senate Health and Welfare Committee back in January 2024. And that we can follow up if you don't have that on hand as well. But that protocol that was submitted has now been incorporated into the Center for Health and Learning has a You Matter for Schools training that's geared for school administrators, teachers, and counselors. And so that protocol has been incorporated into that training. So anyone that is participating and accessing that training now gets trained on that model school protocol that was submitted.
Thank you. Yeah, the link in your presentation is live, so we're good. Thank
Awesome.
you.
Very well.
Mari, I think Mari has another question.
Looking at that model school document that you shared, I noticed we did some work in the legislature around eating disorders. Will you be talking today about that program and your successes and barriers with the eating disorder component?
I won't be addressing that within this presentation, although Dr. Haley McGowan, which is the children's medical director at DMH, has been spearheading that work, and I'm sure would be happy to provide testimony on that or follow up with you.
Great, thank you. We'll look into that.
Yep, thanks, Chris.
Yeah, you're welcome. Moving right along here, just wanting to share about the Governor's Challenge, which was signed. Governor Scott and the Adjutant General Gregory Knight signed on to the Governor's Challenge in the spring of 2022. And the objective of this is to form an interagency military and civilian team of state leaders and policymakers to develop and implement a strategic action plan to prevent and reduce suicide amongst service members, veterans, and their families. There are 3 focus areas, and each of these focus areas has a distinct group that works on either implementing the specific objective that focus area has. So identifying the population and screening for suicide risk, or promoting connectedness and improving care transitions. And then the third one is increasing lethal mean safety and safety planning. For the first focus area, we have created an Ask the Question toolkit for emergency departments. It's a quick access guide that folks can have available to them as they're working with individuals that are experiencing suicidal ideations. And the second focus area, which is has looked at connectedness and improving care transitions. We will be launching in the very, very near future a resource map of Vermont-based clinicians that have shared interest and specialize in working with service members, veterans, and their families, which is what the Governor's Challenge focuses on, as they're at disproportionate risk for suicide.
I just, if I can interject, just because this is such an important piece and I just want to highlight it. I don't know if you or Nick, if he wants to jump in, if you know offhand what sort of the national suicide rate is among veterans, service members, and where Vermont has traditionally fallen in relation to that. And perhaps how the incidence is much higher than in the general population.
Yeah, absolutely. Thanks for bringing that up. And that's a great question. So back in January 2023, we had the most recent reporting that we had and data available was that the US rate per 100,000 was around 20 for suicide deaths amongst veterans. And then in Vermont, it was 83.3. So in Vermont, we know that veteran service members and their families are at much, much higher risk for suicide and attempting suicide.
I don't mean great. I mean, thank you for highlighting that.
Of course.
Chris,
And
I
then
have updated numbers when I speak to the data later.
Okay. Great. And the third focus area is providing a grand rounds presentation to emergency departments. And we also share the Ask the Question toolkit in collaboration with the first priority area. During this grand rounds presentation, there's a focus on the Stanley Brown safety plan. And we also go through counseling on access to lethal means, which is a training that's available. It's an evidence-based practice as well. And we do this grand rounds presentation in collaboration with the National Guard, the Veteran Affairs Office, and the Department of Health and the Department of Mental Health as well. Moving on to the next slide here, just wanting to share a little bit of information about the strategic plan, which was submitted in July of last year. So the Vermont State Strategic Plan for Suicide Prevention aligns with the strategic directions that were outlined in the 2024 National Strategy for Suicide Prevention. That national strategy was submitted in the winter of 2024 and had been updated from 2012. So those 4 strategic directions are community-based suicide prevention, treatment and crisis services, data, quality improvement, and research, which is actually, we diverged a little from the national strategy for the 3rd strategic direction, as at the national strategy, it says surveillance, quality improvement, and research. And we heard from advocates within the state of Vermont that surveillance was not an acceptable term to use there. And then the 4th strategic direction is health equity. And just because we're running up against time here a little bit, I will just point out that the strategic plan can be accessed via link at the bottom of this slide, and also the 2024 national strategy is accessible there as well. Moving on to the next slide, just wanting to provide an update since the strategic plan was submitted in July 2024, that we're turning our plans into action. So I wanted to highlight a few recent achievements in suicide prevention work here in Vermont. So here are a few updates. We've increased awareness in the community by expanding public education and outreach initiatives, just making people aware that there is a state strategic plan as there wasn't one previously. We've established leadership and collaboration by creating an executive committee to oversee the strategic directions. And we've also launched implementation teams that are assigned to the specific strategic directions to drive those targeted initiatives and make sure that we're that we're being accountable to the performance measures that are outlined in the strategic plan. We've invested in innovation as well. We held a request for grant application process in the early fall of 2024 to develop a center of excellence, which is a national best practice. And we'll be working with the Center for Health and Learning and the Vermont Program for Quality in Healthcare to implement this center of excellence and begin the development of that as well. And then we've improved communication and resources There will be a Facing Suicide Vermont newsletter that will be coming out very soon as well to share updates and best practices. And at the end of this presentation, there's a link to sign up for that newsletter, which I would encourage everyone on the committee to sign up for. And then there's a postvention support pilot. As we know, over a landscape scan, that postvention was support was severely lacking. And so we've been targeted with making sure that we're building capacity for postvention within our communities. And then the Suicide Prevention Symposium, which was held during Suicide Prevention Awareness Month in September. And that was the first time since COVID that it was held in person and convened key stakeholders to drive policy research and community action. And so we know that the strategic plan provides the broad vision and mission and charts the path forward to improve our efforts and alignment. And I just wanted to segue to the Vermont Department of Health, as I know that we couldn't do this work without the Department of Health team and wanted to make sure that they're highlighted as well.
Great. Is Nick?
It's me.
Oh, it's you. Oh, okay.
It's all good. So thank you, everyone. I really appreciate allowing the health department to come and be able to talk about the work we're doing in the health department, both with grants and some of the successes. And before I change to the next slide, I also want to specifically express appreciation for people that have been involved in the Facing Suicide Initiative campaign, because someone's in the room. I didn't realize that you were going to be here, so welcome. You're a star.
You're wearing the same shirt.
So to introduce myself, so I am Stephanie Bush. Again, I work at the Department of Health. I am the principal investigator for both the CDC grant and also the GLS Youth Suicide Prevention Grant, and we do a bunch of things around it. For sake of time, just want to say we have been fortunate since 2020 to have two big federal grants that have allowed us to do work both thinking about suicide prevention in the state from a public health approach. As you can see, the time periods and kind of our focus population, which is the overall kind of measure we're looking for is a decrease in both injury and death among kind of adults and also thinking about rural, et cetera. Our youth suicide prevention grant is through SAMHSA, Substance Abuse and Mental Health Services Administration. So we got that grant in mid-2022, as Chris had mentioned, and that runs also for 5 years. And that's focused, there's a couple different populations of focus within that. But really, both of those grants are working to improve systems, as well as thinking about kind of that puzzle piece of suicide prevention. It's all these pieces. It's training, it's support groups, bereavement, et cetera. And the next slide kind of talks about a couple of different highlights. So a question that you had asked, and maybe you want, if you want to ask it again, and I might have some information, but not all of it.
Sure.
Did you want to ask a question?
Thank you. Thank you for the opportunity. I noticed the Facing Suicide campaign uses CDC grant funds, and sounds like they're in, now we know it's the SAMHSA funding. Are you aware, is the money, or do you already have the money? Is it at risk?
Yeah, that's a great, really great question. So the thing that was awesome about the CDC grant is it allowed us the time and space and funding to be able to engage people with experience, partners, stakeholders, et cetera, to really think about what would an awareness campaign look like that is of Vermonters, sharing the stories of Vermonters, and that whole piece around how to promote help seeking, how to help someone who might be struggling. What do you do if you're concerned about someone? And so the Facing Suicide VT initiative was really launched with that funding. Some of the GLS funding will go to continue to support that for continuation, because there's been so much amazing work with it. And we're adding some youth focused and family focused stuff into that website. And so depending on how things happen in the future, and all of this is federal funding, it is something that we are intentionally thinking about, and we'll engage our leadership on.
So do you already have the money, and it's spent or it's already allocated and technically the federal government couldn't claw it back?
So the funding went really towards, in part, like the creation of the website, so the website exists. We have staff that are updating it, et cetera. Some of the other pieces that we're actively working on right now, which I will show here, is expanding our stories of people with lived experience in Vermont. So we're using funding so the initiative exists, the website exists, et cetera. We are looking at these smaller projects with funding that we do have to be able to continue doing that work. Yeah. And if there's additional stuff can definitely provide additional information in the future. Yeah, so I'll just really quickly say that this work, as kind of Chris said, would not be possible without our state level partners, our community partners, people with lived experience being able to really help shape what this work looks like, and really coming together to face suicide. So here is wanting to not drown you all out with paragraphs and paragraphs of text. Wanted to kind of highlight, in thinking of the different buckets of the work that the health department's doing, there's kind of 4 buckets, and these are some different highlights. And depending on what the committee was interested, I can highlight a couple of them. If you're like, ooh, tell me more about the emergency department project, I welcome that. But so in thinking of the work both with GLS and the CDC, we're doing a lot of work around awareness and communications, as Chris said, with the newsletter that's coming out. We've had some really successful work around Men Therapy, which is online learning platform, specifically engaging men, like adult men. Thinking of connectedness, how can we make sure that people have an opportunity to connect? So we're doing some really amazing work around specific populations that are at risk. So some stuff around overdose and suicide prevention within the construction industry, peer support networks for both farmers, which is the little icon there, and first responders, thinking about all the different kind of community strategies. And I do have, because I can't just talk about this, have 3 pages of different kind of summaries of different work. And we would be happy to come back and provide any additional details, because I know that time is very short. From a public health approach, we always try to be data informed and evidence-based. There is a slide later to both talk about the data linkage project, with which I know the committee has experienced before, and our new dashboard. One of the things I think is a really big success is being able to take that dashboard and real-time data and give it to our partners so they can utilize it. So it's not just us collecting data and not sharing it out. And then there's a bunch of place-based work. So engaging with the emergency department for their kind of systems and strategies, healthcare, public healthcare training, thinking of like mental health first aid or CAMS, et cetera. Does anyone have any questions or that would be interested in? Too overwhelmed?
No, actually, I was hoping you could go a little bit more into the man therapy, because this is not something that I have heard of. And how do presumably men, I'm thinking, access this?
Yeah, so happy to talk a little bit more. And I know that we do have a kind of a 1-pager about it and can follow up with any additional information. So Man Therapy is an online, you can think of it as like an online educational website that is very focused towards men. And I have some resources that I'll happily share with you. And so it is, has anyone ever seen like Ron Swanson?
Yeah.
Very Ron Swanson.
Oh my God, yeah.
So it's really, so understanding that in Vermont specifically, that a vast majority of our suicide deaths are men, and also firearms are part of that conversation. So it is geared towards promoting help seeking, being able to engage in educational information around mental health, substance use, relationship, et cetera. So they have a thing where at the beginning, it's like you can do like a 10-point head inspection, like you would go and get your car checked out. You can go and get your head checked out. And we did a paid promotion with that, with funding. We were able to, and there were over 200 people that took that head inspection.
I just took it.
Yeah. And we even have some information around, there's a Get Help Now kind of 988 connection. And there were like at least 10 people that actually
Wow.
said like, let's talk. So that we think that as a success. It was developed out of Colorado. It's evidence-based. It's not for everyone. As I said, very Ron Swanson. And I'll give you, here, you can look at some of the stickers that you can grab. There's like 4 different pieces. But so it's been a big success. And it's a website. We pay into it both for a Vermont page specifically, but then also being able to get metrics. Yeah, if you have any other questions, I'm happy to follow up.
Wait
because
until after your testimony to go take it myself, but.
Yeah, absolutely.
I don't want to skew the data.
Well, and that's actually, I really appreciate you saying that, because so it is kind of, like I said, very Ron Swanson, very geared towards men and people who care about men. So it's like other people if, so it's kind of cool. It's, we were able to pilot it for a couple of years and it really resonated. I think if I remember correctly, I think we looked at Rutland and one other county that I'm not really remember, just to see like if it vibes. Yeah.
Great. Thanks for going into more detail.
And if you want any of the stickers, you can have them because we have grant money to make stickers. So as you're like also going through all this and thinking about it, again, happy to follow up with any questions. So I'm going to touch on some of the data as well. Again, I know in the past we have provided like specific testimony. 3 slides is probably not going to answer all of your questions, but I will just let you know. So what I want to say before kind of digging into the data points, I want to recognize that behind all of these numbers are real people. Every statistic represents a story, a person, a family, and our communities that are impacted by this. So we share this data, we talk about this data to help kind of work to reduce the burden within the department, but also within the state. So I just wanted to say that real quick. So we like to have our little pyramid around morbidity and mortality. So mortality is deaths. So at the top, in Vermont specifically, there's about 125 deaths per year. The next one down is emergency department visits for a suicide attempt. And then after that is emergency department visits for intentional self-harm. And then the bottom of the pyramid, before we add in 98 numbers, is kind of any suicide-related emergency department visit. So this is looking at our Essence data, which is looking at our emergency department visits. It's not the whole picture. We also utilize BREFIS, which is adult risk factor data, for some of that more upstream work. And then we are also going to be doing a little bit more work around YRBS, so youth risk behavior. And I'll talk to that a little bit on the legal means conversation. And then while these kind of 4 pyramids are the standard, I also like to add in the bottom of 988. So thinking about even before people get to the emergency department, and I know that DMH is going to talk about many, many things around the work that they're doing, but so you can kind of see what those numbers are. Very briefly, what I can say is our suicide numbers have gone down a little bit. Our suicide attempt emergency department visit numbers have gone down a little bit. Our intentional self-harm has been kind of the same. And then our overall suicide-related emergency department visits have gone up a little bit. And then also our 90-day calls have gone up a bit. So happy with, I'm sure there's additional questions around all of that. Happy to follow up with all of the details that you want for the questions, unless you have anything specific right this second. Yeah, I feel so close to you. You're like in my peripheral as well.
I didn't keep your man.
It's all right, we can talk later.
Okay,
We can
move
do
on.
more.
Okay, move on. As far as all this information and numbers, do you keep track of what was used or drugs, weapons?
I really appreciate that, and I would like to ask you to wait 3 slides.
Oh, 3 slides.
Yeah. We'll talk about that in just a second. Yeah, any other questions for right this second?
No, I think we're gonna,
Wrap it up? Yeah.
well, no, because I want to get to Alan's question, so let's go through, because I know that we have other guests in the.
Yeah, that sounds great. As you're just waiting for us to get to that slide. So I'll just say, so kind of quickly as well, so looking at our overall suicide numbers and death rates. So 2019 was one of our best years, and then I'm not sure if people remember, something happened during 2020. Lots of things got disrupted. 2021 was our highest number of suicide death numbers in the state and also nationally. And then we've seen, as you can see here, 2 years of decreases since 2021. And what I will also say as well, so as you likely know, our 2024 numbers are not out yet, but currently, and I double checked this last night, we have 90 deaths that are by suicide, and there's 55 pending death certificates. So we are trending lower, but we really won't know until probably like April or May. And we'll gladly obviously share that with you all.
Okay.
Yes.
Just about those pending certificates, are they across 55 across everything, or those that may have a question about methane?
Yeah, that's a great question. So a pending death certificate is just the cause of death has not yet been determined. So that could be there's toxicology, there's other things. It could be that it happened yesterday. Please do not think 55 pending means possibly 55 suicides.
That was my point.
Yeah, exactly. That's a really great question.
All pending.
Yeah. It just hasn't been finalized, essentially.
Yeah.
Yeah. So in a question that we often get is kind of how does Vermont compare to the nation? So as you can see, over the last 15 years, Vermont has consistently been higher than the US rate. We rank 19th by rate, not count, in the nation. And the one thing I will also add to this is that in 2022, we saw a decrease and the rest of the nation saw an increase. I think that is somewhat reflective of all of the amazing work that literally everyone is doing. And I'm fingers crossed that like 2024 is also gonna be lower as well. And to answer your other question around specifically veterans, veterans are nearly 3 times as high of a rate to die by suicide in Vermont compared to all Vermonters. And I don't have the national numbers, but I can get those for you if you would like. So the question that sounds like everyone's waiting for. So one of the things that's also important is talking about lethal means. So do you want to answer your question now or ask your question? Okay. Yeah, so looking at specifically in Vermont, so you can see self-harm on the left side. So about half of self-harm, and so that would be people going to emergency departments are by poisoning. 38% is by cutting, and then looking at suicide deaths, a little bit more than 50% is by firearm, and then suffocation and hanging, and then poisoning. What I will also add is that male suicide deaths make up 73% of all firearm deaths. So that could be homicide, suicide, all of those things. So when we talk about the work that we do, one, suicide, and also males, which is the man therapy conversation. is important. So we've done a bunch of work around, and I know that you have a legislative ask out to the health department. That is my thing I'm doing this afternoon, to talk about all of the things that we're doing. So we have a firearm safety webpage that has data, different work we're doing. And what I can also say is that through the governor's challenge and a bunch of our partners, we've given out at least 2,000 gun locks over the last year and a half or so. And really thinking about how can we engage in that conversation. And there's some interesting work that we're hoping to do to really engage people that own firearms, to think about what is that messaging that works? How can we work to really promote firearm safe storage? One of the things that's exciting for this year, unfortunately, it's going to take a year and a half to get the data, is that our breathless data, so our adult risk surveillance data is around firearms in the household. We're going to be asking that this year at the exact same time that we're asking a why or BS question around how easy is it to get access to a firearm among our middle schoolers and high schools. So we'll be able to look at those two numbers together. Yes.
Mari first and then.
I know we, last session, we talked about, in the suicide assessment, tools in hospitals. I'm a registered nurse at UVM. So I use it regularly. There was conversation about asking a firearms in the house question. Do you know if there has been any movement to involve hospitals?
I'll double check on that. So one of the successes that have been around with our CDC grant is working with VPQHC, specifically with the emergency department. And part of that is around, like, we trained over 300 folks in CALM, which is counseling on access to lethal means. So there is work. And then specifically, we're doing grand rounds through the governor's challenge with emergency departments and hospitals around, like, lethal means and safety planning is a big conversation. So I can give you specific detail. That was part of the thing that I need to send to you guys later today. But yeah.
Thanks, yeah, I think, and it might be challenging too. I know, speaking of someone at the bedside, it's hard to have more initiatives added on to our workload.
Yeah, absolutely. And I'll say real quick. So one of the things that actually has been amazing is our emergency department project work that we've been doing with VPQHC for their systems. And we've actually had all emergency departments engage in that. So yeah, it's great. You go.
Yeah, I really want to get to our next two guests and we're already going to head into our lunch. And I'm asking the committee to indulge me
Some of us
in
have
that.
meetings and we'll have to
Okay,
move on.
we will pop out for that.
Yeah.
So I just want to say, so we have more data stuff we can talk about. These are ways to get involved. I would highly encourage you to sign up for the newsletter. Last time I checked, we had about 60 people signed up for it, and that's me coming out. And again, I appreciate your time. Apologies for going over and would love to talk more.
We got you started late. Thank you for coming in. I know we will probably have you back in at some point this year. Really looking forward to the numbers for 2024. Because as you're aware, this committee did a lot of work around, trying to make a dent in that. So it would be great to sort of see updates. And it's great to see all the work that you've been putting in. Chris put up the timeline and I was like, oh my goodness, my life is flying by. There's a visual representation because I remember steps along the way. So thank you. Thank you, Chris. Thank you, Nick.
Here you are, Chair.
And
And thank you for the diligent collection of data.
Yes.
This program does the awesomest collection of data. I really appreciate that you all do that and have it publicly available on your website. I know.
Yeah.
And the data informs, where the programs need to go
Yeah, absolutely.
and therapy.
And our updated slide should be available at the end of this month, but they're not.
Thank you. So I'm going to try to get to our next guest, Judy Seiler. Oh, there's four? Oh, well, I'm maybe Chopper spilled coffee in there. Oh, we have four. All right, well, if we'd like to get started and if everyone can just sort of be ready. Yeah. Okay, Judy? That's right. I see that.
Oh.
Would anyone like to sit up there together? So we can be active. Yes, exactly, yeah. Yeah. Exactly. So I'm going to give just sort of a timeline. Some people may have to leave and that's okay. So let's try for 5 minutes apiece and we'll extend till 12:10. Okay, great, thank you. Welcome.
Thank you for having us. My name is Judy Seiler, and I'm the president of the board of NAMI Vermont. I've been involved with NAMI over 10 years. I had an uncle with mental illness who was a famous professor, a brother with mental health issues, and we have a daughter adopted from Russia. And so I have a long history of it and used to have seasonal affective disorder myself. So with NAMI, I've taught many classes. I'm a train the trainer for people to teach our signature program. I'm a train the trainer for people to teach support groups. And so I get to talk to a lot of people in the community. The family to family class, I interview, I spend an hour more on the phone with anybody that's interested in the class. So last year I spoke to over 100 families. And so, you know, what we're hearing from families is a lot of isolation, still a lot of stigma, and fear. There's a lot of families that are in their 60s, even 70s, and they'll have a young adult, or, you know, could be somebody in their 40s or 50s, and they're not able to live independently. They're, you know, I mean, not everybody's mental health does not keep them from living independently. As I said, my uncle was a professor, my brother was an engineer, but there are folks that aren't able to live independently, and they're not able to be safe in the community. And so these families are saying, what are we going to do? Because there's not enough community support. Way back when they said we're going to get rid of mental health institutions, you know, hospitals, and we're going to have community support, that never really happened. As you know, all of us, we all have families, loved ones. So that is one of the things that they asked me to advocate for. Is there any way we can have some kind of help? Because when you have a therapist that works with a group of people, that is way much less money than the ER visits. You know, it's what, $1,600 a day when you actually have to go to the retreat. So to keep somebody out of the hospital, out of the ER, safe, and able to work in the community. Often these people can work part-time, or some of them can even work full-time with support. So that's something that is a really critical need for anybody, anywhere in the state, anywhere in the country, is to have some a support system where you can live independently, but there is support. I know a group of families that have some loved ones with disabilities, and they just actually bought a property, and they have about 5 households that are sharing support of their loved ones. It's I think it's in Dummerston or Putney. They bought the property, but what we need is, you know, help with that. And so then another thing that I'd like to talk about today briefly is there's a block grant for writing up something for early psychosis. Well, we already have an evidence-based program. The family to family class is over 20 years old. It is absolutely evidence-based statistics, national statistics. It's taught, it was created, people probably don't realize it was created in Brattleboro by Joyce Berlin. So it's a Vermont thing. It's taught all over the United States and in other countries. So to spend the money to create another program when we have, this is so educational. People take family to family and they're frustrated, they're angry, they're confused. And then after the class, they have empathy and they have understanding and education. And we tell them about resources, you know, what you can do, what Vermont offers. You know, it's educational. How do you talk to somebody? You know, somebody's in crisis or somebody's upset. How do you talk to somebody and make them feel listened and cared for? So we have this program already created. So for that block grant to go out, organization from scratch, you know, NAMI's family to family class is updated every couple of years. There's new science, there's new education. So it's not like an old program. We keep it up to date all the time. And we don't, it's not like a cure-all. We tell people, this is what else you can do. This is where else you can go. So it's resources and education.
Would you mind sending us your that block grant in writing? So we have it.
I'll get Lori to, yeah.
Wants to go next?
I'll be just a couple minutes.
Sure.
I am Jody Gerard, and I am a mother, a wife, a writer, and a continuous survivor of mental health conditions. I live with bipolar disorder, PTSD, and trauma-induced hallucinations. I've been hospitalized over 40 times, so I know what hospitals are like. I'm disheartened that Central Vermont is closing. I'm just going to leave that there. But I just wanted to share that I went to a hospital. This is my latest book that came out called The Long Haul. This is one of the hospitals in Vermont that was not it wasn't clean. It wasn't, there was staff that, I mean, it's hard to get staff now for everything, right? And so there were some people that think that they can kind of tell you what to do all the time. They don't give you enough freedom, right? I mean, you're not free, but I mean, choices. So for example, I wrote this while I was there, but every day they said, the staff said, you get 3 pieces of paper as allotment for the day. And I said, that's right. And so they said, no, that's what you get. You get 3 computer pieces of paper. And so I took my first 3 pages, wrote 3 poems for 3 other patients to see beyond their despair, to see them, something beautiful about them. And then they in turn said, Jody can have my 3 pieces of paper allotment. So we got around that. But isn't that disheartening? I mean, what is paper? I mean, they had a big stack like this and they counted out 3. I don't know. It's just ridiculous. But what I did when I wrote this was the hallway. The one thing that was beautiful about the place was that they had Vermont photographs from John David Geary, who's a Vermont photographer, and they were all landscapes of Vermont. So I chose to jump into the photographs in the hall and write about meeting my love, my husband, and meeting my younger self in these beautiful places besides where I was. And when I left the place, I spoke with Ann Donahue, and she said you had an emergency meeting and you decided you were going to do random inspections there now, which you weren't doing, apparently for the cleanliness. I don't know if that's still happening, but because it was sort of state supported, I just thought it was hard for the ones that were still there. I wasn't there very long, but it was very sad to be in a place where the windows were black. That's unnecessary. You know, that's very unnecessary. There was a beautiful mountain. We couldn't see it because the windows were black. And that's just disheartening. Mold and paint mold in the bathrooms. That's just not acceptable. And so I talked to Ann Donahue and she said, let's try to do something. So then eventually, I just recently this year published this book about it. I'll just let you go around with it. It's online or whatever. But I really appreciate you wanting to listen, and having people be heard. And that's what I'm trying to do. So thank you.
Thank you. And Brian, did you have a real quick question?
Really quick, which was this the old state hospital or was this the new one or a different hospital that you're talking about with the cleanliness issue?
Is it okay for me to tell you where it was?
I think so.
I don't say it in the book.
I was wondering, and that's exactly where.
If you want to tell me off the record, you can if you're worried.
Many of us are interested.
It was just before COVID at Brattleboro Retreat.
Okay.
Yeah. I don't use Amazon, but do our local bookstores like Phoenix Bookstore carry your book?
Not yet, no. I'm selling them as well.
Okay.
Yeah, Jody Gerard.
I'd love to see it get
Yeah.
in some local bookstores.
Yeah.
Congratulations.
Congratulations.
Yeah, I'm gonna go reach out to them, but mostly it's online right now.
Thank you. And thank you for coming in today.
Thank you very much.
Hi, good morning, or
Yes.
good afternoon.
You're good.
I'm going to just read what I typed up really quickly to save everyone some time, and I appreciate the opportunity to come here today and to meet all of you. I've been married for about 38 years, which in today's society is like, wow. I'm also the parent of 3 children, 2 of which have disabilities. I wanted to sort of share with you my experience with mental health, and it began at an early age. I was one of 6 kids, and 2 being from my mother's previous marriage.
I'm sorry, can you share your name?
My name is Lori Moffat.
Okay.
Sorry. Yeah, that's okay, guys. Sorry. And I hail from Bennington, as I think I mentioned, but so anyway, I never really got to know my oldest half brother, because he went to live with our grandparents early on, and you know, I was told it was due to his unmanageable behavior. His visits over the years were always memorable to me. Despite my desire to be close, he treated all of his younger siblings with nothing but contempt. It wasn't until I was much older when I was told that he was sent away because he actually tried to smother our youngest sibling with a pillow. Eventually, he received a diagnosis of narcissism and paranoid schizophrenia, which way back when was like tacky. He refused to accept treatment and burdened our mother with his on-demand need for support via phone. You know, and I myself became her substitute at times. And I can remember one incident being on the phone with him over 5 hours, listening to him tell me about how women talk in code and about how people were stealing medication out of his home. My half-brother was belligerent towards healthcare professionals, and they refused to work with him or to treat him. This made it very difficult for the continuity of care. Over the years, his symptoms increased and included an attempt to harm himself in front of my mother. There was a SWAT team visit to our home while we weren't there, while my mother and I were on vacation, because a friend of his called for a will check on him, and he shut the door on the police officer. So needless to say that our neighbors weren't too happy. My half-brother, you know, he really made it very difficult for the rest of the family. We even had to, when he was living in Florida, we got calls from neighbors saying he was acting erratically, and we had to initiate a bag act on him. He was released within 3 days. So despite all attempts to get him the support and how, you know, treatment that he needed, unless the individual is willing to engage, and unless you reach him at an early age, it just doesn't happen. And he never got that support because mental health services didn't exist for children back then, nor did anyone want to receive a diagnosis or talk about schizophrenia. So, you know, it really was a challenge growing up with having a half-sibling that nobody talked about. As a child, my dad was away often, so my mother was the one in charge, and she was very strict. We always tried very hard to please her by meeting her expectations. I love my parents very much. However, I never realized my mother was so unkind, even while being told that she wished she had drowned us all in the toilet. In the middle and high school, I lost 2 close friends to different blood diseases, 2 other friends to suicide, and another friend from an epileptic seizure. Back then, there was no such thing as school counselors. You know, it just didn't exist. Or to help us process when our friends died. Families didn't talk about mental health or family members' need of psychiatric services. Mental health services for children seemed to be non-existent. The stigma associated with mental health diagnoses was overwhelming, let alone the horrific misperceptions associated with the diagnosis such as schizophrenia and paranoid schizophrenia at that. This often resulted in the entire family being ostracized from friends, family, and the community. Growing up as a tall, big girl, I can assure you there was no one I could talk to about the bullying and discrimination I experienced. There was no one to help me process the feelings of rejection from not just my oldest stepbrother and my mother, but from my other brother who would drive past me as I walked home from snow and ice and told me never to tell anyone that we were related. To be honest, I never really gave any of this any thought. My childhood experiences were just that, my normal childhood experiences. And now I know that those experiences impact you well into adulthood. As a parent of 2 children with disabilities and mental health diagnoses, I attended workshops, seminars, trainings, conferences, anything I could to learn the terminology, and understand how these diagnoses and deficits impacted their ability to develop, learn, communicate, work, maintain interpersonal relationships, and live independently. I attended weekly co-counseling sessions for 12 years to ensure that my children had access to the best possible psychiatric care we could provide and throughout their development, which they or we, when they or we needed it most. Having grown up without mental health services available, I can attest to the value that these services can bring to a family. My own children. We feel fortunate that we've been able to access mental health and other services across the state in support of our children. However, the same cannot be said for many other families living in Vermont. As a member of various boards and committees for many years, providing family voice into the system of care, I've heard countless stories shared by individuals experiencing severe childhood trauma, often leading to addiction, sexual abuse, incarceration, and suicide. I've listened to families describe the barriers preventing them from accessing appropriate mental health care, such as generational poverty, economic discrimination, lack of providers, lack of insurance, cost of insurance and co-pays, no transportation, homelessness, etc. Therefore, I just would like to ask that you continue to listen to the families of Vermont sharing their stories and support them by doing what you can to increase the amount of funding available for mental health services so that all families can access the care that they need. Thank you for your time and consideration.
Thank you. Thank you so much.
You submitted that.
I will. I got here late.
That would be wonderful.
Can I tell you something really quickly because of what Jody shared about the hospital? My daughter, who they never thought would even get through high school with her mental health issues, who's doing amazing. She's almost done her master's in clinical psychology now.
Wow, great.
She's incredible. She's working at the psychiatric ward part-time while doing her master's in Rutland. And it has now become so dangerous that the nurses are quitting. On the one wing, there's a patient that my daughter, who's this little skinny thing, has to smash out of the way. And the male doctor, she said, are resigning because he's so dangerous. And a male nurse rather was just seriously injured this past week. It's given my daughter
Rutland region.
And I will say that we've had ongoing discussions around workplace violence and healthcare, and I will commit to the committee. We will be taking testimony on this
Okay.
relatively shortly.
Okay.
What about the inpatient unit at Rutland?
You're
talking about the inpatient unit at Rutland?
Yes, I am.
Thank you.
I'm sorry, did Lisa want to quickly?
It isn't here.
Okay. Well, thank you so much, and
Thank
I'm so sorry that we truncated your, yes, look, Daisy wanted to say.
There's
something.
another person here.
Oh,
Anyways.
I'm sorry.
Yeah.
Did you want to have a seat?
Yeah, sure. I just never done this before, so I wasn't sure what the, yeah.
Welcome.
Hi, thank you for your time and consideration today. My name is Jeanette Langston. I am the founder and director of Social Tinkering, a Human Connection Project. We're based in Rutland, Vermont. Our entire, I'll just start from the beginning. I notes so I don't forget. Have you ever felt alone? Like no one really cares? And have you ever felt like you didn't fit in somewhere, like you weren't part of the cool crowd and didn't have anyone you could count on to talk to? Do you know someone who has a hard time leaving their home? Maybe they can't drive or walk down the street easily. Maybe you know someone who faces discrimination on a regular basis because they're a bit different than the people around them. Or perhaps you know someone who has been dealing with family estrangement and feel like no one really understands them. All of these and more are reasons that approximately half of US adults report experiencing loneliness with some of the highest rates among young adults. And this is from our 2023, our epidemic of loneliness from the outgoing US Surgeon General, Dr. Vivek Murthy. The American Psychiatric Association's Healthy Minds poll in January 2024 showed that 30% of adults say they have experienced feelings of loneliness at least once a week over the past year, and while 10% say they're lonely every single day. Younger people are much more likely to experience these feelings, with 30% of Americans aged 18 to 34 saying they're lonely every day for several times a week. So today I'm here to talk to you about connection. It's a critical human need that is not being met for many people and how it's causing the epidemic of loneliness in America. We often talk about isolation and loneliness, but there's actually a further upstream, and that is lack of connection that is causing the isolation and loneliness. This is impacting all of us here in Vermont and our communities in all the different ways that we see through all the different issues our communities are facing. In 2021, my team and I formed Social Tinkering Human Connection Project based on our own life experiences around isolation and loneliness and how we found that connection helped us each other thrive.
I'm very sorry. I'm gonna have to interrupt you. I don't believe, I'm not sure you've communicated with our committee assistant to go onto the agenda. We can certainly make time for you a little bit in the afternoon if you wanted to speak. But, you know, we do have a schedule and a protocol for testifying.
Yeah, I actually was told I was on the schedule at 11:50 today.
Okay.
And I sent an outline of my talk and it was received.
Why don't we communicate after this and then see if we can get you sometime this afternoon? Would that be okay?
You do that and I'll be
All right.
good.
Great. Thank you. And Suzie, did you want to wrap? Did you have something you
Oh,
wanted to say?
I was
so we
just
can
gonna
wrap up?
add, that there are so many wonderful stories like those that we just heard. And if you want to hear more, committee and
Yeah.
folks on the side, head down to the pavilion in the Supreme Court area. And there is an entire day of, mingling with folks and learning more about mental health, down there with NAMI and other advocates.
Thank you. Thank you.
for your time.
Thank you.
Appreciate it.
Thank you for your time. And we can go offline.